Greetings and welcome to the International Pediatric Simulation Society podcast. This show is for people passionate about pediatric simulation-based education, training, and research. Podcast hosts are members of IPSS, a global community of multidisciplinary healthcare professionals from over 30 countries, all dedicated to improving the care of infants and children worldwide. Each week, one of our sub-hosts, Christine Bailey, Elaine Ng, Aaron Karn-Bennett, and myself, Samreen Vora, will introduce you to a new guest and bring you into a conversation with simulationists and healthcare professionals from across the world. Come along. Welcome back for this episode of the IPSS, the podcast. Today, we're recording live at IPSSW 2025 in Munich, Germany, chatting with Dr. Vinay Nadkarni, and I have to say, I'm fangirling here. Dr. Nadkarni is an internationally known pediatric simulationist who has helped shape the growth of simulation science over the last decade. Dr. Nadkarni is an American pediatric critical care physician. He is a professor of anesthesiology and critical care and the founding director of the Center for Simulation, Advanced Education, and Innovation and Academy of Resuscitation at the Children's Hospital of Philadelphia. Listen in as he shares how far simulation has come and where it is headed on an international level. And if you weren't able to join IPSSW 2025 in Munich this year, be sure to join us in 2026 to have your own conversation with Dr. Nadkarni and other internationally renowned simulationists. Hello, welcome to the IPSS podcast, Dr. Nadkarni. How are you today?
Fine, thank you.
Well, I'm really excited to have you. You have been someone that I have looked up to in terms of the work that you've done and just establishing simulation as something that's essential throughout healthcare. And so throughout my career, I've looked at your work, and it's going to be really exciting today to talk about where things have come with simulation. We've come a really long ways. I'd love to hear your thoughts on that.
Sure. I do think we've come a long way, and we really think about simulation differently from 25 years ago when I sort of first was exposed to it. And that was around 2000. When we were using very simple mannequins, and the PALS courses, et cetera, were starting to use simulation in a very basic way. Mm-hmm. With dolls as mannequins, they were inert, they really didn't give you much feedback, and we were really doing very basic simulation. And we thought about this as the adults developed SimMan and some of these advanced technological simulators. We started to recognize that interaction was really important. But we still were thinking very narrowly about how we could use advanced technology like computers to generate real physiology or realistic movements and responses. But we were thinking very education-based.
Yeah, education,
very much
training.
Like we're going to teach you something. Yeah. We're going to correct an algorithm. We're going to use it in a way that was really summative, and also when we used it in a formative manner, it really was just taking what we could do and sort of technologically advancing it. And then we started to discover that it wasn't really the technology, but the realism that made the difference. And it sort of opened our minds to other ways we could start to use this. And so instead of just using it to train algorithms and sort of simplistic courses, we started to use it to explore the real world, what we were doing. And so we started to look at individuals, teams, and systems, and started to use it as a probe rather than just a tool to get from A to B. It really was to explore, to be curious, to discover. And that has taken us on a lot of journeys, because with that, we started to understand that because realism was what we were after, that with simple moulage and a few little tricks, we could bring to life and expose and get people to talk about what they were thinking about.
Yeah. Fidelity, the definition, like we
fidelity.
changed that idea of high fidelity being like a mannequin that could do a bunch of things to fidelity of like what we were creating, an environment.
That was so important. Going from fidelity meaning high tech to meaning high realism, I think was kind of the tipping point that opened up the world for simulation-based both education but also sort of processes. And then the other thing that started to come into it, I would say about 10 years later, the recognition that human factors, that engineering, learning about the environment could really feed in, and recognizing as the patient safety movement moved forward and communication and where people were in a room and how a team worked and interacted became recognized as important, all of a sudden there was this big boost for simulation.
Well, there was a shift in even quality and safety work, right? From like the something went wrong,
safety
whose
one,
fault was
fix it,
exactly, to now let's figure out our system. So then seeing simulations where they would actually map out who walked from where, how many times, right? Was kind of that shift to, oh, let's look at our whole system.
I think it also started to expose and reenact positive deviance, workarounds that made things work rather than workarounds which were like deviating from the algorithm and causing poor outcomes. And of course, both of those still occur. But I think we started to recognize that the way we were using simulation could get people from sort of poor performance to good, but it wasn't getting people from good to great. And it was only when we started to expose and look kind of like at safety too, and what makes things go well, that things started to evolve to allow simulation to contribute to going from good to great.
I mean, go as a team going from good to great, right? Like that was the other difference.
Well, as an individual, we started to evolve from rapid cycle deliberate practice for like central lines and procedures, and then started to understand a little more about how to, that was great for procedural training or cognitive training on a given sequence for an individual, but it didn't necessarily get it done by a team at the bedside. And so then peer review, peer training, different modes of debriefing to try to bring forward and allow people to speak up and feel as if they could talk about not just what they did, but why they did it, and discuss what was going on behind the scenes, really, I think, again, gave a little boost. So there was sort of this big sort of jump, and then all of these incremental improvements, I think, that we're still undergoing and still learning from. And one of those like incremental improvements is sort of like virtual reality, augmented reality has now given us another dimension that oftentimes doesn't require the same kind of hardware, but allows us to sort of virtually bring in and remote telesimulation, remote debriefing, asynchronous processes, flipped classrooms. These are things I think that are evolved and evolving that are helping us and that we need help with. But one of the great things about IPSS and the IPS conferences is I think that it lets us come together, talk about what we're doing, but then listen and learn from others who are really sort of creating breakthroughs. And some of these breakthroughs don't seem spectacular at the time, but when you talk to people from across the world, all of a sudden it kind of hits you, wow, that's really different. That's special. I'm going to try that when I go home. And that's what I think is kind of important, really important about these periodic sort of face-to-face gatherings that get us together.
Especially at IPSS, right? That global community is not something I think you can find anywhere else really that comes together, interprofessional, global, and always at the forefront, like you just described, of the newest things that people are doing and coming up with as we're pushing that forward, you know, really.
And it's still in a pediatric context so that people are friendly, they talk to each other, they want to help each other. It's pediatric, so you feel like they're brethren, you know, you feel a real camaraderie, an instant kind of connection around pediatrics, but still a huge breadth of different approaches.
Yes.
That was really one of the things that's remarkable, I think, about some of these other things that are going on. Like, let's talk about PD Stars. It's a group of Indian pediatric simulation experts who have really strategically looked at their country very creatively, created a system of interaction and training that's asynchronous but continuous, connected with WhatsApp, and also has periodic meetings within India, in the different 4 regions of India, just try to build systems of support for people who are interested in moving the field forward.
I mean, that's brilliant, right? India's not a small country, and to come up with a model that works to really extend simulation and improve pediatric care across the country, that's incredible.
And it's not smooth like anything, like IPSS, like PD Stars. It's not smooth and easy. They're politics, they're people, etc. But in general, it gives you a forum to really find people who are like-minded and interested in some of the same things you are.
That is really cool. And it's nice that, I mean, it was PD Stars did get its start kind of coming to IPSS, starting that community, forming that community, meeting with you, and really growing from there. And that's incredible.
Yeah. And so much support. They first were sort of getting support, and now they're really giving support, right? It's kind of coming full circle, goes around, comes around.
That's incredible.
Which is a huge, huge benefit. And they remember their growing pains and what it was like to be out there alone, trying to do it, and then just getting a boost and maybe a little bit of, encouragement to sort of, because like somebody's watching, somebody cares. And those are things that I think IPSS offers also, like with their fellowship program. And it's not so much that it's very different from all other societies. It's just that people care. You link easily with them.
There's a community.
It's a community.
Yeah.
So important.
The fellowship too, that joint fellowship with Inspire, IPSS fellowship, global fellowship. You have these folks from around the world that are meeting regularly, that are working on projects, that have grounded mentors who are helping them get through that. I mean, it's the community that really brings folks together.
Yeah. And it's interesting because I think sometimes when that mentorship comes outside of your own realm, you're a little freer to sort of open your mind and just sort of do different things. But I will say that it's still able to link to important things at your institution or in your life, because it's directed by the person generating the interest, and they're deciding and they're trying to link it with, say, a safety project or a education project or a research project they're trying to get done. And by pulling in this group, they really get support that makes it doable.
Well, and we all know when we work in our own institutions, when we have collaborators outside our institution, and particularly nationally, internationally, it's even more well regarded within our institution as well, to have those expertise.
Sometimes the same idea, when somebody else says it from outside your institution, all of a sudden becomes brilliant. Isn't that amazing?
Exactly. Isn't that amazing? I was like,
I've been saying that for 20 years, and now finally somebody
which I mean, I think good or bad, it's really helpful, right? Then again, going back to that, IPSS offers that community. It offers that space, people who can help you push those ideas forward and push the barriers on whether within your organization or across the countries. I was going to say country, but it's countries.
Gives you a forum to present it. You get academic credit for that. It gives you a forum to collaborate. If you're looking for sort of multi-institutional stuff, then it's easy to find collaborators. If you need a letter of support for either your hospital or your university or your Ministry of Health, whatever it is, it has that presence and is established well enough now that it can really give you a little boost.
And some of that, I agree, like it's just an incredible community that can really give you a boost in so many different ways. And I love the piece about collaborating in multi-site that you talked about. I think that ties to what you were saying, how simulation really made a jump, and we really are pushing forward, doing a lot of things that are beyond just, hey, we're doing this training on these little mannequins. And to be able to do that, you have to be able to do it in an environment where you can do it at different sites, where you can see, hey, okay, I found these results here. I did this small pilot here. How can I see, is this generalized to another place? Or how can it expand? How can I really push the bounds of what we're able to study and look at and understand?
And I think the science of simulation-based education and interventions has progressed also. We used to sort of measure butts in seats and did they learn it? Did they like it? And now we're really getting into, if they liked it and learned it, do they use it?
Yes.
Did they do it? And then if they did it improve patient, family, provider outcome?
Yes.
One of the cool things I think also is we're expanding beyond just the patient, but we're also really looking at the system, the providers, their mental health, their longevity. There's so many other parameters that we can expand to, not just the patient, like the child, but their family, the providers, the community they're going to.
The system.
We're getting better at measuring that stuff.
Well, and even thinking about the fact that simulation impacts that stuff so that we can measure it, right? We just did a project in my institution. We had gotten virtual reality goggles and the software. We're going to run some scenarios. And I know everybody's kind of doing it. Hey, it's really cool. But the outcome that we decided to look at was retention of our nurses, because they had been asking for more hands-on help and training, especially when they're going to be transitioning to taking care of really high acuity patients. And we thought, this is going to be really incredible. We're going to bring, and it was interprofessional that we were doing this, and with the new technology that everybody was like really excited to try out. When they feel like the organization is invested in them, brings them together, creates a community with each other. So thinking about different outcomes that we're going to measure than just, hey, they did a scenario and they liked it, or even that they translate to the bedside, all the way to thinking about, hey, it's going to help retain them here.
And what more is an administration going to listen to than retention of nurses? I mean, that is such an issue around the world. If you could affect that even a little bit, then you've got their ear, and man, your program's going to grow and foster.
So I feel like you're right. We've moved so far from what are we looking at? What are the outcomes simulation can impact, and in what ways? It's pretty incredible to think about. So are there any particular projects that you're working on right now that you're really excited about and that you want to share a little bit about?
I'm excited about a lot of projects. There's so much going on.
I know you're doing travel.
Let me tell you, like from this conference, I'm actually going to the World Health Organization.
Oh, nice.
They're having a World Health Organization assembly, and they've created what they call an Acute Care Action Network that's focused on emergency, critical care, and life-saving operations, ECO they call it. What we're trying to do is to put together simulation-based training at the lowest, through the middle, through the highest resources that can be a template, a WHO standard to look at danger signs and the 5 biggest killers of kids across the world. So if you think about cardiac arrest, stroke, complications of childbirth like asphyxia, maternal hemorrhage, if you think about road traffic accidents and stopping the bleed, and you think about sepsis, that kills 88% of the under 5 kids. That's like 8 million kids a year around the world. And most of those are in low resource settings. So we are trying to work with the WHO to create a program that would, each one of those entities has their own kind of training courses, like a basic life support, PALS, those kinds of courses. But it doesn't really put together all the things one needs for life-saving first aid, because in a community, you don't know which one of those things is going to happen. And so by putting together and thinking proactively about how we can make low-cost, low-tech, realistic simulations that would help to train this in many different settings that would be contextual and adaptable to many of those settings, we think we can start in the community, to the EMS systems, to the district, and then to the tertiary hospitals, to create a grade-aided program and toolkits that could be sort of put together. So I'm really excited about that.
Wild. How cool you can impact, what would you say, like 8 million? Is that?
A year.
Oh my gosh, 8 million a year lives. That's unbelievable.
And it's a huge project, and of course it's not going to happen overnight.
Of course not.
But organizations like IPSS, many people in that organization are already thinking and working on many things in this area. And if we can use that as a think tank to sort of crowdsource the solution, it would just be heaven.
Talk about getting simulation to the next level. Right? Not just to the bedside, but to the world. Right?
Where it's needed. Right. And then have, like we're finding with neonatal resuscitation, that those low resource settings for low dose, high frequency training with very simple tools is leading the world. Like in February, a New England Journal of Medicine article on the reduction of infant mortality and maternal mortality based on low-dose, high-frequency, simulation-based training at the point of care, low dose and high frequency, making a difference. 40% reduction in birth asphyxia and 70% reduction in their maternal mortality rates from maternal hemorrhage.
That's incredible.
Is that cool? That's really amazing, really isn't
cool. It? Yeah. I mean, that's really taking it to the bedside and changing lives. That's really, really cool. Well, I'm really excited about your project with the WHO too. I'm like, how can I get involved? That's really awesome.
You can.
That's really, really cool. So I think that this has been really awesome. Our hope is there's going to be more episodes coming out about PD Stars. We're hoping to talk to some folks with PD Stars and a couple of these other programs that you've mentioned. I know you mentioned Stop the Bleed, and I know there's other programs around the country like Impact. So hopefully we'll be doing episodes and people will continue to tune in.
That would be great. They're doing really great work.
Yeah. Anything else you'd like to share before we...
No, I just think I'm happy to be here at IPSS. I think it's a great conference. I love it.
And if they're not here this year, come next year.
Come next year. Come early, come often, right?
There you go.
Yeah.
I love it. All right. Well, thank you very much for your time.
Thank you for listening to this episode of the IPSS podcast. A special thanks to our behind-the-scenes producer, the talented Denish Kumar, and to the Starship Foundation for providing the equipment that makes this podcast possible. Join us next time.